We'll carry on now and hear from Andy Warshaw. Andy doesn't need any introduction. He's an icon in American surgery, but he's really contributed significantly to the American College of Surgeons in several ways. He's currently the treasurer, but also runs the Health Policy Advocacy Group, which is really the oversight structure for the American College of Surgeons advocacy efforts. And I can't say enough about Andy's contributions in helping us get organized at one of the most critical times for all of us as surgeons. Andy?
Thank you, Dr. Hoyt, Dr. Ratner. It's a pleasure to be here. My job is to give you a bit about what the American College of Surgeons and you can be doing in this time of change. And I would emphasize from the start that most of what we are hearing about the Accountable Care Act and health reform is totally in a intermediate phase right now, and I'll try to show you some of that. I don't have anything to disclose. I wish I did, but that's the way life is. These are the elements of what is available to surgeons through the American College of Surgeons, largely in its Washington office. And there are a number of groups, a number of approaches which look at what's going on in payment, in structure, and what we can do in an ongoing way about this. One of the really tricky aspects when you get very emotional about some aspect of healthcare reform, whether you're for it, against it, for part of it, against part of it, is what are your core principles? What are the things that anchor you in trying to make a decision about any particular element? And the college, on your behalf, really has taken the view that what is important is that healthcare, delivery of healthcare, should be patient-centered, physician-led, based on quality, and ultimately, in this world, has to reduce costs. So that's the matrix that has to be put together. Now, in the past year, before the passage of the bill, most of our activities were really reactive and had to do with what came down from which committee or which side of Congress on a day-to-day basis. So just to give you an example of how confusing it was and how much this led to really lack of understanding of what the college was doing. And I like to use the analogy of the Olympic javelin team that won the toss and elected to receive. And I often, when I was representing the college, felt that it would be good to have one of those lucite barriers right in front. In any case, the original House bill did have a number of aspects that the college and you would strongly support, which include repeal of the flawed Medicare physician payment system, the Sustainable Growth Rate, or SGR. It did not include the Independent Payment Advisory Board. I'll come back to that a little bit later. Then the bill that came out of the Senate was really totally transposed. It did not address the Medicare physician payment and did include the IPAB. So, what do you do? Who do you support? How do you work through that? And the answer is it's difficult. At the end of the day, there were a few elements that the college did achieve. We're often asked, well, why didn't you get rid of the IPAB or whatever else? The answer is that there is political reality that you have to deal with. And often you must decide how to keep your friends, how not to alienate your representatives that you work hard to get a relationship with, and you fight the battles that you have some chance of winning. So one aspect, for example, that you may not be aware of is that the bill did originally, until the last minute, contain a $395 annual Medicare application fee, which would have applied to everybody in this room. But at the last minute, largely through the activities of the college, that was deleted. The 5% a tax on cosmetic surgery, a number of other items here. A big one is the 10% bonus to rural surgeons, which was going to come out of the hides of everybody, of the specialists, but is not. These are relatively small in the big picture, but you just have to be around to fight another day. Now, the problem with the Affordable Care Act, Accountable Care Act, is that it's somewhere between 1,000 and 2,000 pages of legislation, which then translates into thousands of decisions by HHS and others. And ultimately, it's 30,000 pages of regulations that will determine what really is going to happen. You can look at this as absolutely unassailable, but it also is opportunities. It's opportunities for us to be a part of the process, for working with committees, for developing those relationships so that we can have a voice in what does happen. The legislation is simply the opening act. How it plays out is a daily lobbying effort, and just this past few days ago, Dr. Hoyt and I, for example, were at an agency of HHS trying to deal with how surgical care could be delivered in underserved areas. That's what needs to go on. That's what you need to be involved in. But basically, there's just a huge job, and if you try to take it on as a whole, you can't do it. You've got to piece it out and deal with it. So at the moment, as you know, there are a lot of challenges to the act, and it is being challenged largely by the Republicans. It's not going to be repealed. It's not going to get, even if the House passes a repeal bill, it's not going to get through the Senate, and it's not going to get through the administration. The judicial challenge is perhaps more serious because it's focusing on the individual mandate for insurance, and there is at least one judicial view that if that cannot be severed. If you knock down the mandate for insurance, the whole bill rides with that. So I don't think that's going to happen, but that's something to keep your eye on. So on the payment reform, I'm going to try to touch very briefly on these various issues. On payment reform, there's been a great deal that has been going on. Much of it is around the fact that this SGR is at the center of increasing costs, which are within a constrained budget, and that means decreasing the payments to providers, as you are well aware. The problem, you know, I naively a while ago thought, well, why don't you simply, you know, just write it off? The problem is you can't. It's money that's on your credit card, figuratively speaking, and basically we have to figure out how to reduce the cost of care to make up for what amounts to almost $400 billion that's on the credit card right now. Nobody has the answer to that. The can keeps getting kicked down the road. Nobody's got the answer, but we have to come up with one. At the moment, we have a respite till the end of 2011 at the moment to come up with something brilliant, and the college is trying to do that. IPAB is another flashpoint. It's a problem because it is an unelected board. It's all appointed. They can make decisions about physician payment, among other areas. There are no practicing physicians on this, and there's a 30-day window, which if Congress doesn't repeal what they have to say, it becomes law. The Medicare spending is what is at the focus of this, but you can rest assured that the private insurers will follow what Medicare does in some close way. So the problem here is, as stated, I'm not going to read all through this. I've mentioned some of it, but basically it's a concept that is perhaps going to put us at double jeopardy if the IPAB makes decisions that are on top of, piggybacked on what the SGR does. It's a problem, and it goes into effect in 2015. There is congressional action to try to repeal the IPAB. The House has has already passed it. It's not, as I said before about the overall act, it's not going to get by the Senate or the administration. So practical politics, realpolitik, really says, okay, how about trying to figure out how it can be altered that will defang it, that will not make it as difficult as it is. And that's work in progress and much too much to get into. Accountable care organizations, that's coming down the line. I believe that after months of delay, finally the policies have been broadcast or put out, I think this morning, as a matter of fact. And the question is, what is an accountable care organization? So in the interest of full disclosure, nobody knows. It can be lots of things. It can be combinations of hospitals and doctors. It can be combinations of physician organizations. It can be across regions to include private practitioners in onesies and twosies outside of the major organizations. But basically, it is intended to to coordinate care and hopefully will produce savings. In fact, there is no real evidence that they will produce savings. So it may improve the quality of care, but not necessarily take care of that problem with the SGR. Another aspect is that if you reduce the cost of care, is it going to be easier in high-cost areas than low-cost areas after you get the money out after the first year? What's left to do it in subsequent years? And the need to keep that going is going to be very difficult. It's also going to be a little bit like throwing the money on the floor in front of a bunch of hungry wolves, because who's going to get it? How is it going to be split among the different doctors in an accountable care organization? How about nurses, hospitals, chronic care, and so on? So these things are really a problem. Another one that for surgeons I think is important is, if you think back a little bit to gatekeeper type models, this is not the same, but it's not that different either, that while patient choice will remain, the referral to a surgeon may be constrained. You may never get to see that patient. As an example, and I'll just take your attention to the graph on the right, in the years involved here, early 2000s, these are all the American health plans and their rates of referral to specialists. This is the rates of referral to specialists in the National Health Service in Great Britain. So in what amounts to an accountable care organization in some ways, they just never get to a surgeon, and that's going to be an issue that we need to keep our eye on. Bundling is another aspect that's part of this law. What does bundling mean? It can mean anything from an episode of care around, let's say, a colectomy, or it could be care for a year around the entire care of a patient. There are lots of different models. And in both of these cases, because we don't know what they really mean and what they specifically will mean for surgeons, the college has put together a consulting group, or has hired a consulting group, to really analyze the implications of both of these mechanisms of payment for how it would affect surgeons, but even more, how we can get involved in the process to not simply be the recipients, but the designers. And so there needs to be framing how this will work, who's going to be involved, and ultimately, again, I can't emphasize enough, we need to be involved at the beginning, at the design phase. For analysis and design, for participation, and it's not just us, it's all of our natural partners. It's anesthesia, it's the hospitals, there is experience to learn from, and we're at the very early and beginning phase of that experience. Workforce, I think you're all very aware of. There is an enormous shortage of surgeons, not just primary care physicians. That's a public. We need to get that out and appreciated better by the public and by the legislators. They've really been brainwashed with the idea that primary care is the only area where there's a shortage. But the surgical specialties, general surgery in particular, and this graph I think shows it as well as any, the primary care areas, OBGYN, internal medicine, they've been increasing over the years, whereas the yellow bar at the right is the net change in numbers of surgeons that are available. That's a problem. And Buzz Cooper at the University of Pennsylvania has put this out. The demand, as you can see, is that straight line. The blue line is what's going to happen if we simply go on as business as usual. And in the middle, you can modify it some by doing all the things that people have at the moment thought of to do by increasing the number of surgeons from 1,000 a year output to doubling that. And how you do that's another question, but even that doesn't solve the problem. So increasing medical schools and residency slots, how long is that going to take? 15 years before you begin to open the spigot? Not going to work. Financial incentives, how many of you would choose to be general surgeons taking night call and trauma and so on instead of the wonderful work that you do? It's not just a matter of dollars, and there aren't enough dollars in the system any more than there are enough dollars in the system to persuade people to go into primary care. And so I think one of the jobs that we're going to need to do is to figure out how to use the workforce that we have. Regionalization, the accountable care organizations may be part of that. The putting together, synergizing the work of different specialists, and ultimately, my own personal view is that the acute care surgeon is going to progressively become the general surgeon of the future. It's been said that the definition of general surgery is the on-call surgeon, and that's going to take something different. The heritage of the college is in quality, and we have to come back to that because that, I think, is going to be the key to many of the questions that I've been raising. And in particular, I'll put this forward as a way of our getting to the table in terms of costs. Dr. Hutter's going to speak more about quality later on, but I'll just take something from NSQIP and that high outlier end of the spectrum can also be called a high cost end of the spectrum. And if we can reduce that, we can bring something to the table that's very substantial. So the data that we have at the moment through NSQIP looking only at postoperative complications, just taking that as a slice. This is published data in the Annals of Surgery that about 280 complications, postoperative complications per hospital could be reduced on an annual basis. If the cost of a single complication averages $15,000 to $25,000, it's pie in the sky at the moment, but we could bring to the table $25 billion a year when somebody says, what surgery are you going to do to help bend the cost curve? If you then multiply that out through all the hospitals in the country and all of the other things that we can deal with in terms of reducing costs, there's some real money here. The college has used this circle of learning to bring that to bear, to look at, to measure outcomes through NSQIP and the other databases that are out there and are being built. Innovation, what the people at that minimally invasive surgeons and so on are bringing that can reduce time in the hospital and complications. These need to be trialed and the best evidence taken from that and ultimately coming to the highest quality of surgical care. And finally, I'd just comment about tort reform. This is high on everybody's list of why isn't the college doing something about this. The fact is that there's been a lot of effort in that regard. Once again, it's gotten past the House a couple of times, never gotten past the Senate, and basically it's just not going to happen at the federal level. There are some state level successes in this regard, but ultimately we have to get past simply the cap on non-economic damages and as the solution to everything, and begin to think about alternatives to liability reform where we're doing something positive, not simply saying that I don't want to pay out so much money, but start thinking about, for example, if we could agree on the best practices and guidelines for care, and if that did take off that far end of the outliers, and patients got care that was improved, and if you did it right and the toilet still got flushed, then you can't be accountable, because you can't get down to zero problems. So there should be safe harbors if you did it right, and you know, you're not going to prevent every single wound infection. Let's face it. And when I was in training in the last century, if you know, the mortality rate for a colectomy was 15% when I was an intern. Now, if somebody has a hangnail that comes loose, it's doctor, what'd you do wrong? So we have to begin to define what doctors do right, and protect them accordingly. This is all still work in progress, but the point over and over again is that we need to be creative, we need to be innovative, we need to figure out what needs to be done. Now, not all of the ACA is bad. There is a distinct emphasis on going from simply volume to quality and efficiency, value in other words, pay for performance, not just for reporting, the reduction of preventable conditions readmission, these pilots that are being worked on, and it is, I think, a good thing that coverage has been expanded. So coming down to why isn't Washington working better for us, and again, you know, my friend John Armstrong is going to be talking about this more, but basically we are disunited. The Joint Surgical Advocacy Conference that took place earlier this week was a beautiful example of surgeons clawing at each other for whatever it was that they view as the right thing or the piece of the action. 4% of surgeons in the American College are members of the PAC. It's hard to convince Congress that we really have an axe in here if that's the level of concern. And 250 out of 250,000 potential surgeons showed up at JSAC. When the college tries to mount a political action and says, call your congressman, we'll make it easy, all you need to, here's the telephone number, here's the canned message, it'll take a minute, or here's the button you push for an email, you know what the response rate is? 3%. So it's hard to convince Congress that we're really in the game. If they say, well, you know, there are all these threats about dropping out of Medicare, more than 95% of us are in Medicare. Congress says, you know, doesn't seem to be a problem, does it? So there's a public relations problem here among ourselves as well as outside of ourselves that we need to work on. We've tried to put this together as a surgical coalition across all of the surgical groups and anesthesia. And there are things that are easy to agree on, including quality initiatives, the payment reform and alternative payment systems, having an adequate workforce. When it comes down to things like repealing IPAB, there are groups that feel very strongly that they cannot sign on to any agenda unless we say repeal IPAB. There are others who say that's going to waste our ammunition. And we need to put our efforts into something more than that. There are groups that want to say that you can have unlimited balance billing based on a private contract in advance of service for what you do. So can you picture, Mrs. Jones, I know you need your colon out for cancer, but if you want me to do it, we're going to charge double the usual rate. Of course, you don't have to use me. The people are being put in an unfair position. The college has been, with its principle that patient care comes first, has not been willing to support that. So once again, we got sundered on the rocks, and in fact, there is no united agenda that's come out of it. We tried to say, let's put down the things that we agree on and not fight about the ones that we don't on either end of the spectrum. So far, that has not worked. So in an effort to try to work some of these things out, to communicate with our fellows, to begin to find out what you're thinking, what we're thinking, how to put that together, there is a new Health Policy Advisory Council that's just getting off the ground. It is open to everyone. Any of you who want to participate, and I hope you will, can be part of this network to figure out how we can get our ideas and efforts together. Ultimately, this is all going to come down to quality. I can't tell you how useless it is to go to Congress and say, you know, you're just not giving us enough money. If you put things in terms of our compensation, you know, they'll say thank you very much, and the door is right over there. Don't slam it on your way out. It has to be about better patient care and all that can mean. So the college now has this Inspiring Quality campaign. It is intended to be addressed not only to legislators, but to our colleagues, to hospitals, to the public. There are many different aspects of it, many different ways to work this out. Dr. Hoyt comes, I think he sleeps with his traveling bag and is going around the country along with a number of others to try to get this message out that we are about quality, and with better quality, all these other aspects will follow. This is the logo now, and I'll leave it at that. You're going to hear more. Thank you very much.
Thanks, Andy. That was an excellent summary.